Hello, my name is Richard Sekel, and today I'm going to be presenting how to write an independent medical report. An independent medical report is quite different to the types of reports that we're used to writing in our normal clinical practice, in the treating role. An independent medical report, of course, requires all of the skills and clinical abilities that are involved in normal clinical work. But independent medical examination consultancy is a separate expertise in its own right, and even I would call it a subspecialty. To write an independent medical report requires substantially greater amounts of information than might go into a normal clinical report. The methodology of writing a report as a treating doctor is proactive. Steps that we take as clinicians is proactive. We're seeking an undiagnosed condition, we're investigating and treating it, and we're providing advice to the patient. IME work is in fact quite different. As an IME consultant, we're actually working retroactively. That is, we're not coming up with a new diagnosis, but we're confirming or refuting an already existing diagnosis or claimed diagnosis. In addition to the clinical work, an IME doctor assesses non-clinical information as well, which I'll talk about in a short while. And we're not providing information to the patient, whom in fact for today's video I won't refer to as a patient anymore, because as we're not the treating doctor, this person is not our patient. So, for want of a better word, I will call him or her a claimant. Also, we write a report. The IME report we write is far more formalised and far more comprehensive than a normal clinical report that one might write, for example, from a specialist to a general practitioner. Now, overriding everything in today's presentation, the IME consultant still must remain professional, objective, honest, balanced, unbiased, fair, comprehensive, and of course professional ethics, avoiding harm, observing courtesy, respect, modesty, etc., all remain paramount as they do in the normal clinical situation. So the goal of doctors, the goal of treating doctors is of course medicine, diagnosing and treating somebody. The goal of an independent medical examiner is in fact quite different. If I can be rude enough to suggest that the goal of an IME doctor is to provide information regarding money, regarding payment or not payment. Now, of course, it's not payment to ourselves that we're talking about, but nevertheless, it's payment to a claimant. And that those forms of claimant for which we're providing the raw data includes loss of wages, treatment, and oddly enough, although treatment is by far the greatest expense that we would normally encounter for the patient in our clinical practice, but treatment costs are usually the least substantial figures in independent medical work. So loss of wages, treatment, pain and suffering, and I won't go into what that means, but basically it's an amount of money that somebody else, not a doctor, calculates in regard to the amount of difficulties that a person is going through from a claimed injury. Other expenses for which our raw data provides information about payments includes payment for domestic assistance and occasionally payment for aids or home modifications or travel expenses, etc. And there are various other sources as well. An independent medical consultant is a service provider. We are also, as clinicians, service providers in today's modern dialogue, but in the independent medical assessment arena, we are even more so service providers. We're assisting the referrer to make a correct, fair decision. And whether the referrer is plaintiff or respondent makes no difference, of course. And we're assisting them to make fair decisions by providing medical opinions, and even more importantly, in many situations, by documenting all of the available evidence for those opinions so that others, non-doctors, can use that information. The goal of a useful IME report is to provide scientifically accurate information in a way that's useful and manageable to the readers, And it's therefore essential that we record evidence. In legal terms, the lawyers call what we refer to as evidence, they refer to it as reasons, but it's evidence in our terminology. The concept of balance of probabilities is of particular importance in IME work. As clinicians, as treating doctors, of course, it's extremely important that we get as close to 100% certain as we can be that our diagnosis and that our methods of treatment are correct. We have to be close to 100%. However, in compensation work, in IME work, it's quite different because we're not providing treatment and we can't guarantee absolute certainty. We're dealing with others, with lawyers, with insurers, etc. And their jurisdictions require them to only talk in terms of probability, which means greater than 50% likely to be correct. And so that's the case in just about all of the personal injury jurisdictions that we all deal with. The balance of probabilities being more likely to be correct than not is the required level of certainty. Therefore, we have to use evidence-based methods to provide a clear, decisive, unequivocal opinion. Basically, by that I mean, very often we can't be absolutely certain that what we're saying is correct, but we have to be certain that we are more likely to be correct than not. It's an odd concept for us as clinicians, but just being more likely than not is as far as we're expected to go. There are many types of IME reports, and I won't go through all of those. I've just listed them off in this slide. By far the most common in most jurisdictions is workers' compensation or motor accidents, but there can also be sickness and accident, total disability, personal liability, for example, slipping over in a shopping mall and claiming against the shopping mall, or in Australia, comp care as a separate version of workers' compensation, superannuation claims, disability pension, medical negligence, and we've got a whole separate video covering how to do medical negligence for those doctors involved in that. And of particular interest is the concept of respondent versus claimant reports. Now, it might seem an odd situation to state because, of course, we have to give the same opinion, be fair and balanced, no matter who has referred to us. But very often the questions themselves are different. So therefore the reporter is going to actually be responding to a different set of questions. So pitfalls. When writing IME reports, it's essential that we avoid advising claimants on anything really. It's important that we don't try to imply, suggest, allude to even slightly a diagnosis or comments on treatment that they have received or that they haven't received but should receive, or the likelihood that they're going to be successful in their claim, or even that they should have other investigations than what have been performed. We should not comment to the claimant. Of course, all of these things will go into our IME report, but we should avoid advising this information to the client. We shouldn't comment on prognosis or reassurance even that you're going to get better. That seems like such an easy, basic thing to do. Oh, don't worry, Mr. Smith, what you've got is not a major condition and you'll get better. That so often causes major dramas, that sort of a comment. Or even recommending a second opinion. Now, it's far more common than one might think that as a person is leaving our room after perhaps being with us for an hour or often very much more than an hour, the claimant might say, "You've been so nice, doctor, and so comprehensive. No doctor has spoken to me like that before. Please just tell me, what do you think? They're just confidential, just between you and me." It's very, very enticing. Avoid commenting. The only correct answer I might suggest is, look, I'm not your treating doctor. Do discuss it with your treating doctor. And that's as far as any comment should ever go. If we don't, we can cause far more harm than good in many respects. One of which is that once you've given even a word of advice to a claimant, you have put yourself in the role of the treating doctor and are no longer an independent medical examiner. You become a treating consultant. And therefore you've moved outside of your proper role. And secondly, of course, you're giving advice contrary or separate from the treating doctor, and you're usurping the role of a treating clinician, which can never be a good thing. Further pitfalls. Only ask need-to-know questions. However, there are substantial numbers of questions that are greater than might occur in the clinical role that are need-to-know questions, but nevertheless, be wary of it. Avoid reporting unnecessary personal or intrusive details such as skin colour or tattoos or irrelevant comments about the spouse, etc. However, the second point on this slide is of particular importance if you want to do IME reports successfully, and that is to control the order of the history taking. Very often, the claimant is coming in and not unreasonably expects to just be talking about the accident and will burst into conversation about the accident. But for reasons that I'll cover in the next few minutes, I suggest that we should not talk about the claimed accident first, but to get background information for reasons that I'll say. So if you can control the order of the history taking to be in the same order that you're going to be writing your reports, it makes the dictation of the report later so much easier, and it also ensures that you haven't omitted things, because if you go out of order out of your normal order, the way you will obtain the information, you are at significant risk of forgetting to ask important questions that you won't have another opportunity of asking once the claimant has left the room. So some dictation recommendations. When dictating the report after the claimant has left the room, I strongly recommend that you decide your diagnosis before you even commence dictating the report, or typing it if you're clever enough to type your own reports. Decide where you're going to go with this report and how exactly you're going to go before you start the first sentence. Avoid self-conflicting opinions, a very common situation that I encounter because I've been going for many years into one of the insurance companies to once per week as an outside consultant, just advising on management. And one of the major issues that the claims officers have is that doctors to whom the claimant has been referred by that same insurer provides a report where the doctor is saying yes, then no, then yes, then no, and there are fluctuating opinions through the report, so that by the time you get to the end, you have no idea what the doctor intended. And unfortunately, sometimes the doctor will give all the raw data to suggest X, and by the time the doctor gets to the end of the report, the diagnosis is not X. So it's really quite confusing. So be wary of fluctuating opinions, and again, that can be avoided by deciding your diagnosis before you commence the report. Remember not to give vague responses, I'm not sure. We can always be sure about the balance of probabilities, that it's more likely than not that one side of an opinion is more certain than the other. So don't be equivocal, but when necessary, you can use the term balance of probabilities. On the balance of probabilities, Mr. Smith did or did not have such an injury, it's still there or not there anymore, etc. Use simple, precise, clear language, avoiding safety language, avoiding arm's length language like, I consider that he would be fit for, is very arm's length. It's much better to use a straight term like he is fit for. Now, if you're working on the balance of probabilities, then you're able to make a firm statement like that. If necessary, you'll say, on the balance of probabilities, he is fit for, but not I consider. And I recommend, I'm using the word I now, but I recommend that in our reports that we never use the word I or me. It's always based on the evidence rather than it is my opinion, but we'll cover that in a short while. So other dictation recommendations: use short sentences and short paragraphs. Explain uncommon medical terms. Of course, it's not necessary to explain to most readers of IME reports the meaning of things like intervertebral disc, but you would want to explain spondylolisthesis, for example. And dictation recommendations always ensure that you answer the referrer's questions. In reports, it's very handy if you include a lot of headings. You divide your report into many different sections. There are many advantages for that. First of all, our referring clients and all readers, whether it's our clients or somebody else's clients, prefer to have headings. It assists them and us as a rapid search tool if all they're interested in is a particular area of your report. If it's under the headings, it's so much easier to find. And it's also, for ourselves, a wonderful self-check. It helps us to avoid omitting something. If we've got headings, then we know we've covered all the areas. So the suggested order of headings, as I said before, many doctors start straight off with the history of present complaint and then give other information later in the report, and also ask that other information later in the interview with the claimant. I suggest that that's not the best way for various reasons. One is because it causes you to often forget to seek the information, the substantial information. If you burst straight into the accident and its treatment, then you tend to forget the other information, which often in independent reports is perhaps even more important than, or at least equally important than, the information regarding the accident. Very often the referral has been sent to you either by the plaintiff solicitor or by the respondent solicitor to advise whether pre-existing conditions were or were not relevant. So whatever is the case, whether pre-existing conditions were relevant or were not, it's really important for us to remember to seek that information comprehensively. And the best way to do it is to do it as the first part of your interview, and also to include it in the first part of your report. Secondly, a second reason why it's important to do it in that order is that if you start straight into the accident, then you're not able to compare how that accident has affected the person unless you already have the data, having read the data as the reader, or having collected the data in your own mind as the interviewer. If you haven't collected that data first, you can't compare. So my preferred order is past medical history first. That's background information, but it also makes sense to a claimant that you're actually asking medical questions about their medical situation. That kind of makes sense, you're a doctor. That's the first. Secondly, an occupational history. Thirdly, the social history. If you burst straight into social history first, people might think you're being unreasonably intrusive. But providing the past medical history and then the occupational history, then the social history makes a lot of sense. Occasionally, only rarely, claimants say, "Doctor, why are you asking about that information?" And there's an easy answer to that. Mr. Smith, part of the reason that you're referred here is to see how this accident has affected you, not only in whether you need treatment or not, but also whether you're able to return to work and whether you're able to look after yourself at home, and if not, who looks after you, and so on. So I need to know how you were before the accident so I can compare how you are after the accident. I've never had a claimant upset with answering all of the otherwise apparently intrusive questions, and they should not be appearing to be intrusive, but they've never had a claimant complain after they get that explanation. Then you obtain the history of the present complaint, and I'll talk about that in a few minutes. And then under a separate heading, I list off injuries. It's really handy to list off the injuries, and I'll explain why. But it's listing off the injuries as a separate issue from listing off the accident itself. And then other headings: initial treatment, progress medical history, activities that the person was and was not able to do after the accident, and changing as time goes on. The current status: how is the person today in my clinic room? Listing off and describing investigations, and I'll talk more about these other headings in a moment. Obviously, the physical examination observations, and the diagnosis and opinion. Many doctors end their IME reports at the diagnosis and opinion section, and may then just answer questions that the referrer has asked, without providing other information. But I'm suggesting that we should have several more headings between the diagnosis and opinion section and when we answer the questions at the end of the report. Those other headings that go in between include causation, a very important issue, especially in IME work. That is of far greater relevance to us as IME doctors than it is to clinicians. Clinicians just need to know what the diagnosis is. Occasionally the cause is important, but often it actually is not so important in deciding how you're going to diagnose and to treat a person. In IME work, for obvious reasons, it's very important. That's the subject of a totally different video, so I won't go into that about causation. Another heading is future medical treatment, reasonable necessity of future medical treatment in regard to this accident. Another separate heading from diagnosis and opinion is prognosis. I'll talk about that later. Another heading, very important, is employment capacity. Another is domestic assistance. That's very often a requirement, especially in workers' compensation and motor accident compensation in all jurisdictions in Australia, I'm quite sure. And another heading, a very important heading that I'll talk about very briefly today because it's again a separate video, that other heading is evidence, evidence for the opinions. And then of course separately impairment assessment if that's required. It usually is in workers' comp, a third party. So now to give a bit more information about each of those headings, or most of those headings. Past medical history. Ask specifically in past medical history about major past illnesses and injuries and operations, fractures, etc. Also ask specifically about previous work-related or motor vehicle accidents or even other personal injury accidents such as falling over in a shopping mall. Ask specifically, have you ever had any other compensable injury? Obviously using whatever level of language is required so that question is understood. Also the previous history of the current claim conditions. If a person is complaining of back pain now, specifically ask, rather than just asking, have you ever had any problems before, ask specifically, have you ever had back problems before, for example. And also get information about the current regular medication. Personal and social history. The pre-injury personal physical activities and sporting activities are very important so that we can compare how that person's ability to undertake activities of daily living have altered, if they have, as a result of the claimed accident. It also helps to assess the needs for domestic assistance and activities of daily living after the accident, if that has altered. It also can help us to seek whether there were other potential causes of an injury. If the person, for example, was a significant athlete and is complaining of a particular localized injury, might the sporting activities have been at least a substantial contributing factor, if not the main cause of the claimed symptom. Occupational history should include, briefly, past education and the past experience and skills, especially if the person is now claiming that he or she can't go back to the same work that they were doing before the accident. So we need to know what work opportunities this person might have if we also agree that the person is unfit for the work that they were doing immediately before the accident. We also need to know the immediate pre-injury employment, and we need to know that in substantial detail. Even if you are an orthopedic surgeon or some other specialist where work experience and occupational factors have not been part of your formal clinical training, as an IME consultant, I would suggest that you need to have some level of understanding and experience of work. And the fact is that the great majority of people in the general community, including, let's say, orthopedic surgeons, do have substantial knowledge of what work is like generally out there. But we all, whether you are to be an occupational physician or not be an occupational physician, need to obtain the information about the work before the accident in terms of medical concepts. And those medical concepts are the functional movements of the body. Don't just give a job title that he was a labourer or he worked in a factory, because worked in a factory could mean anything from sitting like I am now and watching widgets go past on a production line with every now and again, every 60 seconds having to pick up something that was wrong, to perhaps very labour-intensive work, including bending of the back and lifting weights, etc. So, functional movements of the body in the work that the person was doing immediately before the accident, maximum weights that the person would be required to lift before the accident, number of hours per day and days per week, etc. And another question is, did the person have more than one job concurrently before the accident? Now we're getting onto the history of the present complaint. It's important for us to get details of the mechanism of the accident and also get a full comprehensive description of the immediate post-accident details. Usually there is a wealth of information available to assess if the claimed trauma was or was not significant. We all might think that many doctors just describe that this person lifted a heavy weight, has had back pain, and that's it. Or that the person was involved in a motor vehicle accident, or maybe even was involved in a head-on motor vehicle accident, and since then has been complaining of neck pain, back pain, shoulder pain, and knee pain. And that's it. In fact, the documents sent by most referrers, plaintiff referrers or respondent referrers, includes a lot more information that can assist us in deciding whether the trauma that this person's body sustained was or was not of a major kind, and whether the various claimed injuries are likely or not likely to have occurred. And with our clinical skills added onto the substantial non-clinical information that we can obtain from the documents and from the history from the person, we can have a much better judgment of the level of injury sustained. There are many questions. I think I've counted in the next 3 slides 23 questions that I routinely ask, let's say, in regard to a motor vehicle accident. So this is just as an example. We'll use the motor vehicle accident as an example. Was a seatbelt worn? Was it a rear, side or head-on collision? What was the position of the person in the car, in the driver's seat or in the rear passenger seat, on the offside or near side of the car? What was the position of the car? What was the position of where the person was sitting in comparison to where the impact occurred on the car? What was the speed of the claimant's car? What was the speed of the other car? Very often people will say, oh, the speed of the other car was very fast. And then you say, did you see the car approaching? No, I'm just saying that because it was a loud bang and there was a dent on my car, so it was very fast. So now we have a bit more specific information, in as much as we don't have specific information because we don't know that it was a significant speed of the other car. Did the claimant's car strike any other object after the initial impact? Did that car roll over? Did the person's body, any part of the person's body, strike the inside of the car cabin, such as the knee against the dashboard, etc.? Now we know, for example, in a rear-end collision, that the person's body travels backwards compared to the car, not forwards. You're pushed back into the seat, or more to the point, the car is pushed forwards relative to your body, which stays in one spot where the car moves forward, so that your body's gone backwards, and the likelihood of striking your knee against the dashboard or your head against the steering wheel when wearing a properly fitted seatbelt in a rear-end collision is very remote, as we're advised by the biomechanical engineers. Did the claimant's airbags deploy? Did the other car's airbags deploy? And that's of a particular importance if it was a rear-end collision. So if the car that caused the accident, having had a front-on collision of the other car, if that impact was not sufficient to cause the fitted airbags of the other car to deploy, then it's a bit of indirect information that it was not a major impact. How long was it before the claimant stood out of the car? Were other passengers in the claimant's car injured? Were the driver and passengers in the other car injured? Most commonly, when we see people who've been involved in a rear-end collision, or in any collision, most commonly, although the claimant considers that they were injured, the person who caused the accident, more often than not, was not injured. Obviously, that doesn't imply if it was a major impact. Then did the police attend, and if so, quote from the police officer's report, because there's substantial information in the police officer's report commonly describing the true nature of the accident, generally an assessment of the speeds, and they have some skills in assessing that. It's guesswork, of course, but assessment. What did the injured claimant complain of at the time of the accident? Commonly that's reported, not always. Another bit of information is about an ambulance report. First of all, in many accidents that we see, motor accidents that we see, nobody considers it necessary to call for an ambulance at the time of the accident because nobody considers themselves injured. It's only afterwards that they consider that they've had an accident. Nevertheless, often passers-by call an ambulance, or of course people involved in the accident might consider it necessary to call an ambulance. Then, if the ambulance attended, did the ambulance offer treatment, or was it considered not necessary? And did the ambulance transport the claimed person? And the ambulance report itself, if the ambulance person attended, the report is very helpful in providing true contemporaneous information, listing many details: the car damage, the assessed speeds, that the person did self-extract or couldn't get out of the car, the initial symptoms and the signs, etc. The ambulance officer's reports are very helpful. Similarly, if the person was transported to hospital, then information from the hospital records are particularly important. The triage nurse's record is often very important contemporaneous information before anybody has had a thought of how to falsify information, if that's the nature of the situation. That commonly has not occurred by the time that the triage nurse has seen the person. So the information in the triage nurse's document is very handy. Of course, as are the records in the doctor's records. So I quote heavily from the emergency department doctor's records, listing the details, including what body regions and symptoms were not mentioned on day one that the claimant is now claiming to have sustained now. So if it wasn't mentioned in the initial hospital records, the likelihood is, of course, that it was not a major trauma. It doesn't mean that some parts of the body don't get a bit more sore afterwards, but generally major injuries cause pain immediately, as we all know. In addition, the emergency department investigation results, including what parts of the body did not require x-rays or scans on the first day. Again, adding further indirect information about whether parts of the body were or were not significantly injured, how long the person stayed in the emergency department, and of course quoting separately from the discharge summary, especially obtaining information about the review. Commonly, when people are leaving the emergency department, the only review is return if necessary, or see your GP in a few days, but occasionally there are recommendations to or there's an arrangement to be reviewed by a specialist in outpatients, or commonly no review is required at all. All of this gives substantial information about the severity of the accident. Then the initial record of the GP, I quote from this extensively also, the initial GP record commonly provides substantial information, greater information than later records. How long was it before the person first saw their GP after the accident? Provides some information. Was it the next day, or was it 2 weeks or 4 weeks later? Had the person already gone off to see a solicitor before they'd seen the GP, etc.? Obviously, if it's a significant injury, that's not going to be an issue. The initial body regions that the GP refers to compared to regions of the body that the GP refers to as having been injured later on, implying that the person has had time to think about it, modify the information, whether genuinely or not. The initial level, in the initial GP's records, the initial level of the symptoms compared to the current symptoms. As we all know in clinical medicine, the great majority of injuries gradually improve with time and don't deteriorate with time. That's not always the case, but the great majority of cases we know that's the case. So if the symptoms continue to get worse and worse and more body regions involved, then it might give us some indirect information about the veracity of this person. The initial treatment that the GP offered, was it just minor treatment for soft tissue injuries, or was it immediately for significant injuries? And most importantly, reviewing the physical examination that the GP undertook on the day of the accident. Did the GP only refer to symptoms that the person described, pain or tenderness, which are symptoms, they're not signs in compensable medicine, or did the GP observe abnormal objective signs that we would all agree are objective signs? And the same, of course, applies to the physical examination of the doctors in hospital on the day of the accident. It's very important to remember that range of motion and tenderness can be under the patient's conscious control, and therefore we might like to consider whether we consider that to be a symptom or a sign in compensable medicine. Obviously, ranges of motion and tenderness are deemed to be signs in clinical medicine where there's no tertiary gain or secondary gain to be considered. More information regarding the level of impact of the accident. How long was it between various GP visits? How long was it until the GP decided to refer the person for further investigations? Translate the clinical relevance of the radiologist's otherwise scary words, translated for claims officers so that they can understand themselves the relevance of words like bulging discs. How long, if at all, was it that the GP took before referring the person to a specialist for a treating specialist? What was the treating specialist's initial impression of this person? How long was the person off work, if at all? It's also very handy, very informative to advise what was the stated attitude of the person to returning to work, whether it's pre-injury work or suitable duties, and how long. Now, under the heading of injuries, as I said before, it's really helpful to list the injuries rather than writing separate paragraphs. It assists the reader, of course, it just seems much more succinct and clear, but it's also a wonderful checklist for yourself when you're later reading your draft report and you're looking at the physical examination and other sections, just to make sure that you've covered all of the injuries, so that you've physically examined all the relevant injured areas, that you've mentioned them all in the diagnosis section, that you've done a permanent impairment of them if that's part of your brief, and that you've talked about future medical treatment of all of those injured areas. When commenting upon the initial treatment and progress, comment on whether the immediate treatment was for what would appear to be urgent or not urgent conditions. Was there an early referral to a specialist, and if so, was that reasonably necessary? And whether the treatment was for objective abnormal signs reported by treating doctors, or just because the person was complaining of pain or reduced range of motion without any obvious cause for that. Under the heading of activities, after you've described the injuries and the treatment, activities, a heading on activities is very important, because very often that, or sometimes that might be the only important issue that the referrer is requesting of you, although they've requested a whole lot of other information, but that might be the particular point of this assessment. So, under the heading of activities, record from the information you get from the claimant and documents how long the person was off work, the details of upgraded return to work, the best of the information you can get, the claimant's attitude to returning to work, very important component in all of this, what the person says and how that seems to fit in the activities of daily living other than work as well. Essential activities such as housework, returning to hobbies, perhaps sport or going to the gym, etc. Then list off as a separate heading current status. How does the person say that he or she is today? And what does the documented evidence indicate that the doctors are treating today compared to the original injuries? Current symptoms, how long is it since the person last attended a doctor, a GP or specialist, projected future treatment, etc. Investigations. Of particular importance here is not just to quote a radiologist's whole report or even a radiologist's conclusion, unless that conclusion is very clear. But very often, radiologists' reports include a whole lot of scary sounding words that are only scary if you're not a doctor. So they really do need to be interpreted to confirm that it is evidence of a significant injury or it's not evidence of a significant injury. So it's important to interpret investigations and reports in non-medical terms to our non-medical readers. Physical examination. Remember that we all know this, I don't need to preach to us, of course, but so often in reports are written as if symptoms are pathology. Symptoms are not pathology. Symptoms are what the person claims and can give us a direction towards pathology in many cases, but not always. And because we're doing independent medical reports rather than treating reports, our role is to be independent and to stand back and to judge from all of the information we have whether those symptoms are more likely, one, not more likely, to be evidence of a genuine significant injury. So physical examination. In IME work, the following are not objective signs, as they are objective signs in clinical medicine, in treating medicine. Reduced range of motion due to pain is not an objective sign because it doesn't confirm or refute anything further than what we knew when we read the documents before the person walked in the room. Tenderness is what the person says. That is, the person says, when I'm pressing the person in a spot, oh, that's sore, doctor. That's again subjective or dependent upon the claimant's own statements, not objective information. So therefore, in our reports, rather than saying there is pain when he raises his arm, we don't know that there's pain. That's part of our role to assess. The only thing that we can write with certainty is Mr. Smith complained of pain, or Mr. Smith complained of tenderness when I pressed him here, pressed him on the shoulder, when, etc. So Mr. Smith complained of pain when he was pressed on his right shoulder, rather than he had pain or he had tenderness. And similarly, rather than saying there is reduced flexion, it's more correct to say, and more balanced and fair to say, he did not flex beyond 30 degrees, he did not flex his right knee beyond 30 degrees because of a complaint of pain in the knee. Also in physical examination, explain the significance of your observations in non-medical terms. Often, of course, that's not necessary, but sometimes it is. Sometimes when explaining the relevance, for example, of cogwheel movements, if we just say there was cogwheel movements, that's very nice when you're writing to a GP. We don't have to explain what that means, or we shouldn't have to. When you're writing to a non-doctor, the fact that there's cogwheel movements has its own implications, and we need to explain what that means here in the physical examination section. So cogwheel movements, suggestive of, etc. We should comment on consistency. We're observing the person in many different ways. We're observing them from the moment they walk in the room to the moment they walk out of the room. We might even see them on the street out, after the consultation or after the assessment. And all of that is observations, and we need to comment on consistency of all the issues that we noted during the assessment. Is there evidence of apparent exaggeration, or was there no evidence of exaggeration? Equally important to comment on that, whichever way it was. Also comment on non-organic signs, commonly previously known as Waddell's validation signs. Professor Waddell himself didn't like Professor Waddell didn't like for his name to be attached to it, but nevertheless, we all know them as signs to confirm or refute that a person did or did not appear to be genuine. They're just indications. There are many, many other factors, but they're of relevance as well. And we need to explain not only the observation, but what does it mean to a non-doctor in non-medical terms. In the diagnosis and opinion section, again, provide a clear and unequivocal diagnosis. If we're not absolutely certain, as I said before, we have to be clear on the balance of probabilities for the reasons that I explained before. When we're using medical terminology, we should use medical terminology in our reports. We should give the correct medical diagnosis, but we should also explain that in lay terms in less common situations. Most conditions of the spine don't need a separate explanation in lay terms, but from time to time, and with experience, you'll know which conditions a claims officer would know and which ones they wouldn't. Explain it in lay terms. The diagnosis and opinion should be based on our knowledge, our skill and expertise and scientific knowledge of the natural medical history of the claimed condition. Sometimes we might need to quote medical reference data, research papers, etc. Very often that's not necessary, but we might need to. So our diagnosis and opinion should be based on the natural medical history of the condition, based on the evidence, and based on the consistency of all of the factors that we've assessed until now. The big question to ask is, do the objective physical findings support the subjective complaints? Avoid in your reports, avoid attempting to explain something, avoiding an explanation of the claimant's inconsistencies. We can't know what's going on in the person's mind. We can only observe what we can observe. We can observe the history that we've received and the documentation and the physical signs and the consistency of those, and we can put all of that together as a reasonable or unreasonable presentation, but we should not try to explain why the person says that they've got something, but we don't consider objectively that that's present. Don't try to explain it. Don't try to diagnose outside of your area of expertise. As a psychiatrist, as a musculoskeletal specialist, don't try to diagnose psychiatric conditions, for example. Don't ever use the term malingerer, because the term malingerer implies that you know that this person is intentionally rather than unintentionally or subconsciously overstating or magnifying symptoms. So don't use the term malingerer, because it's beyond, I would suggest, beyond our area of expertise to be able to state why the person is not responding in a consistent manner, if that's what we're observing. Avoid providing the self-contradicting opinions that I described before, that you gave a whole lot of data that suggested X, but the diagnosis turns out to be, you provide the diagnosis of Y. Prognosis versus attitude. Prognosis is a medical term. It's commonly, I would suggest, misused by doctors who are doing IME reports. The doctor might, appropriately, consider that there is nothing particularly wrong with the person now, or there's nothing wrong at all, but the person is, let's say, refusing to return to work. And therefore, the prognosis of return to work is guarded, or that although there's nothing physically wrong with the person is in a belief system that there's nothing wrong, or is stating that there's nothing wrong, and therefore the prognosis is guarded. I would suggest that that's not the correct use of the term prognosis. Prognosis is a medical term, meaning the expected natural medical history of that condition in people who do not have secondary gain, based on your medical, physical diagnosis. It's unrelated to attitude. For, let's say, unreasonable reluctance to work, don't state prognosis is guarded, rather state this person has a negative attitude. Attitude is an administrative issue, not a medical one. Prognosis is a medical issue, but attitude is an administrative issue. Reporting on future medical treatment. So after the diagnosis and opinion section, it's very helpful to report on future medical treatment, whether future treatment is reasonably necessary with regard to the claimed injury from that accident, whether, let's say, ongoing physiotherapy or other physical therapies are resulting in sustained benefit and are therefore within or outside of evidence-based medicine guidelines, and the duration of physical therapies, whether they're reasonable or not. Employment capacity, comment on past, present and future employment capacity. And as I said before, whether you're an occupational physician or some other sort of doctor, we all need to comment within our relevant knowledge on the ability of that person's body to continue doing various sorts of work. We're not experts on jobs, but we are experts on the person can move or not move, can bend, not bend, lift such weights, etc. So employment capacity should not refer to just job titles, but the body movements and tasks. That's the important component of the employment capacity section. Domestic assistance, similarly, compare the person's ability to undertake domestic chores now to the way the person was before the accident. Very often, for example, in motor vehicle accidents, we might be seeing a pensioner, a 75-year-old pensioner with severe arthritis, etc., who might already have had significant needs for domestic assistance before the accident. So to compare how, if any, the accident has altered that person's needs for domestic assistance in the past and in the future, and what sort of domestic assistance in general terms. Now, evidence for the medical opinions. This is a separate video where we're discussing the evidence section at the end of a report. But I do suggest in very brief lines that you do have a separate section at the end after you've provided your diagnosis and opinion and comments on causation and reasonableness of relating this accident and these injuries to that accident. Separate from that, list off the evidence for all of the opinions you've recorded under a separate heading in dot points. It's the factual data. I'll just very briefly list some of the comments, but there's a whole separate video about this. Past medical history. Did the claimed injuries already exist before the accident? The mechanism of the injury, was it major or minor? The initial treatment, was it urgent or not? The progress history, did the person need to have specialist treatment, and if so, just briefly what? Documented evidence of abnormal objective physical signs, or the lack of. The claimant's stated attitude. The clinical significance of investigations, just listing these off, one sentence per asterisk, not whole paragraphs again, because you've recorded this comprehensively in the earlier part of the report. Objective physical signs, that there were or were not objective physical signs on your physical examination today. The consistency of those physical signs. The presence perhaps of non-organic signs suggesting that the person is not fully genuine or whatever else might be going on, that this is not due to these injuries. And whether the whole of this presentation is consistent with the natural medical history of the claimed injuries. Similarly, impairment commonly is requested in a separate report. It depends on the jurisdiction and the referrer. I'm not going to go into impairment now because, of course, there are several separate videos on impairment assessment. But just a caution that sometimes doctors provide impairment assessment using the wrong methodology for that particular jurisdiction. So you need to know, for example, if we're using the American Medical Association guides, which is the correct guides, which are the guidelines that cover those guides that might have been written specifically for the Western Australian Workers' Comp or the South Australian Motor Accidents, etc., or Comcare. So, in summary, every disease or injury has a natural medical history, and in conclusion, obtain an extensive early history, stay objective and fair and professional, trust your clinical knowledge and your general knowledge, and use all of your forensic skills. Thank you.